Okay, hello guys. Today we continue topic fluid and electrolyte management of the surgical patient. It's part 2. I think it more interesting than the last one, but it's just for your opinion. Okay, in this part we will talk about reason of body fluid changes, and we'll talk about classification and some normal exchange of fluid, some disturbance in fluid balance, and volume control. The healthy person consumes an average of 200 milliliters of water per day, approximately 75% from oral intake and the rest extracted from solid foods. Daily water losses include 800 to 1200 milliliters in urine, 250 milliliters in stool, and 600 milliliters in insensible losses. Insensible losses of water occur through both the skin, it's like 75%, and lungs, 25%. And all of these insensible losses can change if patient if patient have factors like fever, hypermetabolism, and hyperventilation. Sensible water losses, such as sweating or pathologic loss of gastrointestinal fluids, vary widely, but these include the loss of electrolytes as well as water. And I will show you a table where you see water exchange for people who are men and weight of patients like 60-80 kilograms. And there you see all what changes in organisms per day. Kidneys. To clear the products of metabolisms, the kidneys must excrete a minimum of 500 to 800 milliliters of urine per day, regardless of the amount of oral intake. The typically individual consumes 3 to 5 grams of dietary salt per day, with the balance maintained by the kidneys. This hyponatremia or hypovolemia sodium excretion can be reduced to as little as 1 milliequivalents D or maximized to as much as 5,000 milliequivalents in day to achieve balance, except in people with salt wasting kidneys. Sweet is hypotonic, and sweeting usually results is only a small sodium loss. When we talk about surgery, we need to understand that gastrointestinal tract is our all, and for surgeons, losses from gastrointestinal tract is most interesting. When we talk about GI losses, they are isotonic to slightly hypotonic and contribute little to get gain or loss of free water when measured and appropriately replaced by isotonic salt solutions. Disorders in fluid balance may be classified into three general categories: disturbance in volume, concentrations, and composition. Three. Isotonic gain or loss of salt solution results in extracellular volume changes with little impact on intracellular fluid volume. If free water is added or, or lost from the ECF, water will pass between the ECF and intracellular fluid until solid concentration or osmolarity is equalized between the compartments. Unlike with sodium, the concentration of most other ions in the ECF can be altered without significant changes in the total number of osmotically active particles, producing only a compositional changes. For instance, doubling the serum potassium concentration will profoundly alter myocardial function without significantly altering volume or concentration of the fluid spaces. Unlike with sodium, the concentration of most other ions in the ECF can be altered without significant change in the total number of osmotically active particles, producing only a compositional change. For instance, doubling the serum potassium concentration will profoundly alter myocardial function without significantly altering volume or concentration of the fluid spaces. Extracellular volume deficit is the most common fluid disorder in surgical patients and can be either acute or chronic. Acute volume deficit is associated with cardiovascular and central nervous system signs, whereas chronic deficits display tissue signs such as a decrease in skin turgor and sunken eyes. In addition to cardiovascular and central nervous system signs, we will see it in table some forward. Laboratory examination may reveal an elevated blood urea nitrogen level if the deficit is severe enough to reduce glomerular filtration and hemoconcentration. Urine osmolarity usually will be higher than serum osmolarity, and urine sodium will be low, typically less than 20 milliequivalents per liter. Serum sodium concentration does not necessarily reflect volume status and therefore may be high, normal, or low when a volume deficit is present. The most common causes of volume deficit in surgical patients is a loss of gastrointestinal fluids from nasogastric suction, vomiting, diarrhea, or intracutaneous fistula. In addition, sequestration secondary to soft tissue injuries, burns, and intra-abdominal processes such as peritonitis, obstruction, or prolonged surgery can also lead to massive volume deficits. Extracellular volume excess may be iatrogenic or secondary to renal dysfunction, congestive heart failure, or cirrhosis. Both plasma and intestinal volumes usually are increased. Symptoms are primarily pulmonary and cardiovascular. We will see it in table what will be forward. In fit patients, edema and hyperdynamic circulation are common and well tolerated. However, the elderly and patients with cardiac disease may quickly develop congestive heart failure, and pulmonary edema is response to only a moderate volume excess. And there we see signs and symptoms of volume disturbance. And you can see that if we have volume deficit, patient will have weight loss and decreased skin turgor. If we have excess of volume, patient will have weight gain and peripheral edema. And then of course we see a cardiac, renal, gastrointestinal and pulmonary systems, and what will happen if they have volume deficit and volume excess. And the last table, what I want to show you, it's a table of composition of gastrointestinal secretions, and there you see what changes patient have in all gastrointestinal tracts. Volume control. Volume changes are sensed by both osmoreceptors and baroreceptors. When we talk about osmoreceptors, they are specialized sensors that detected even small changes in fluid osmolality and drive changes in thirst and diuresis through the kidneys. For example, when plasma osmolality is increased, thirst is stimulated and water consumption increases. Also, the exact cell mechanism is not known. Additionally, the hypothalamus is stimulated to secrete vasopressin, which increase water reabsorption in the kidneys. Together, these two mechanisms return the plasma osmolality to normal. Baroreceptors also modulate volume in response to changes in pressure and circulation volume through specialized pressure sensors located in the aortic arc and carotid sinuses. Baroreceptor responses are both neural through sympathetic and parasympathetic pathways, and hormonal through substances including renin-angiotensin, aldosterone, atrial natriuretic peptide, and renal prostaglandins. The next result of alterations in renal sodium excretion and free water reabsorption is restoration of volume to the normal state. This part of lecture about fluid electrolytes exchange of patient in surgery is finished. Be healthy, guys, and don't forget that you need know it. Bye bye.